Dr. McCullough is Vice Chief of Medicine at Baylor University Medical Center in Dallas and is Principal Faculty in Internal Medicine for the Texas A&M University Health Sciences Center. He has over 1,000 publications and is a recognized authority on the role of chronic kidney disease as a cardiovascular risk state. He has published in New England Journal, Journal of American Medical Association, and other top journals. He is co-editor of Reviews in Cardiovascular Medicine and is associated editor of the American Journal of Cardiology. He has given numerous presentations worldwide, and he is president of the Cardiorenal Society of America, which is an organization dedicated to bringing cardiologists and nephrologists to work together on this emerging problem of cardiorenal syndromes. And as you can see from his presentation, this is an area of a great controversy, the overlap between how to treat AFib and heart failure with the presence of chronic kidney disease and end-stage renal disease.
Hello, this is Dr. Peter McCullough from Baylor University Medical Center in Dallas, Texas, and it's my pleasure to present this webinar today titled Atrial Fibrillation and Heart Failure in Chronic Kidney Disease. I want to again thank each and every one of you for joining this teleconference. I'll follow this outline and make a few points with respect to atrial fibrillation and heart failure as they relate to patients with chronic kidney disease in the pre-dialysis phase of chronic kidney disease and those who are receiving renal replacement therapy. The first points are regarding atrial fibrillation, and I'm an internist and cardiologist, so I have a really kind of a medical, internal medicine and cardiology orientation towards atrial fibrillation, but recognize that it affects a lot of patients that we manage with respect to chronic kidney disease and end-stage renal disease. And by way of review, keep in mind that in normal sinus rhythm, it takes quite a bit of coordination between the sinoatrial node to have a relatively coordinated atrial depolarization, have all of those impulses arrive at the atrioventricular node within a reasonable time span, and then have depolarization of the bundle of His and the right and left bundles to have a coordinated ventricular contraction. In the setting of atrial distension, increased atrial pressures, cardiac fibrosis, valvular disease, ventricular disease, and cardiomyopathy, it's not hard to imagine that the perfection of sinus rhythm would be lost. And in fact, the atrium would start to, in a sense, do their own thing with respect to depolarization and repolarization. And so in atrial fibrillation, as shown on the right-hand side of the screen, there really are 600 or more independent little wavelets occurring. And in fact, if we were to count the oscillations, they'd be about 600 beats per minute. And so atrial fibrillation in many ways is the default rhythm as we move into older age in the presence of long-standing hypertension, diabetes, chronic kidney disease. Now, it's true that in younger individuals that paroxysmal atrial fibrillation does originate out of the pulmonary veins, and then we can go in and isolate those pulmonary veins using ablation techniques and have reasonable degrees of success. But the atrial fibrillation we see in chronic disease in the elderly largely is due to, it's secondary to atrial disease. And very importantly, atrial fibrillation begets atrial fibrillation. So the more atrial fibrillation is the predominant rhythm, the greater the left and right atrial dilatation, the electromechanical dissociation of those chambers occur. And so atrial fibrillation can and does become a permanent rhythm in many individuals if we are unsuccessful in managing the abnormality back into sinus rhythm. Now, the danger with atrial fibrillation is the risk of stroke, as shown here. So atrial fibrillation at this point in time accounts for roughly 20% of all strokes. Atrial fibrillation strokes tend to be larger and tend to have greater neurologic, permanent neurologic deficits than strokes not due to atrial fibrillation. Importantly, our anticoagulation anticoagulation with warfarin, as shown on this slide, which is very effective. Warfarin has a 90% risk reduction for stroke and systemic embolism, is very tightly related to an INR between 2 and 3. INRs above 3, we begin to have progressively higher intracranial bleeding risks. INRs below 2, we really have a sharp increase in the risk of cardioembolic stroke. What we know that the time in therapeutic range with warfarin is related to, again, not only to efficacy, but time in therapeutic range does decline in individuals as estimated GFR declines. And in this analysis here, you can see individuals who have an estimated GFR below 30 or are on dialysis. Those individuals have roughly a 15% drop-off in the, or at least 10% drop-off in the overall time in therapeutic range compared to patients with normal renal function. And in adjusted analyses, both renal function and time in therapeutic range were independently associated with the odds of adverse events. So the association of between time in therapeutic range and adverse events is really not modified by differing the GFR. So with atrial fibrillation, we use what's called clinimetric tools. These are scores to estimate the risk of stroke. And in 2002, the CHADS-2 score was first presented. And this is just a way of assigning points to comorbidities, heart failure, hypertension, age greater than 75, diabetes, or a prior stroke or TIA, which had 2 points, and adding them up. And then in 2012, this was refined to include more categories and give more specificity with respect to heart failure, with respect to, and adding valvular disease and even a lower age bracket in female age. The CHADS and CHADS-VAS2 scores not only predict stroke and atrial fibrillation, they actually predict the development of atrial fibrillation itself. They predict all-cause mortality. The CHADS and CHADS-VAS2 scores are not specific at all for a stroke. They're kind of general comorbidity scores. Now, what we know is when we apply these scores in populations and actually look for thrombus in the left atrium, in fact, it does hold out. Once we get to CHADS, higher CHADS-VAS scores of 3, 4, or 5, we start to see meaningful occurrences of thrombus within the left atrium. So this is a check on internal validity of the CHADS-VAS scoring system. Now, the incidence of atrial fibrillation, as I've mentioned, is related to atrial fibrillation risk factors. And so here are some of them listed here. And we can anticipate in some populations that, in fact, atrial fibrillation will occur. This analysis was in patients with end-stage renal disease with 6 or more factors. And it's not hard to get there with respect to age, hypertension, heart failure, peripheral arterial disease, chronic obstructive pulmonary disease. So the teaching point of this slide is among those with end-stage renal disease, as we start to accrue these common general medical problems, the risk of atrial fibrillation can approach about 50%. Now, with the CHADS and CHADS-VAS score, what we understand in the general population is a score of 0, so no more comorbidities, or 1. It's reasonable to use aspirin as anticoagulation, and 325 milligrams per day, what was tested in the early stroke prevention atrial fibrillation trials. Once we have a CHADS-VAS score of 2 or greater, all experts agree anticoagulation is warranted. And here it's with warfarin, and with great enthusiasm in the general population, we've moved from warfarin to novel anticoagulants, and with some controversy, the use of both warfarin and novel anticoagulants in patients with kidney disease. Now, as I mentioned, the predicted per patient prevalence of atrial fibrillation is related to comorbidities, but across these populations of chronic kidney disease or end-stage renal disease, you can see the point prevalence here ranges anywhere from 1 or 2% up to about 1/4 of the population of patients having atrial fibrillation. Right now, I'm the CCU attending at Baylor in Dallas, and over 50% of our inpatient service has atrial fibrillation as one of their medical problems. This is an important slide making the point that as we have worsened levels of renal function, we not only have higher CHADS, CHADS2 and CHADS-VASc scoring patients, but we also tend to get a drop-off in the frequency of patients who are anticoagulated. So at very high CHADS and CHADS-VASc scores, patients have so many risks that in fact many are not anticoagulated. They've had prior intracranial hemorrhage, they've had GI hemorrhage, and we have such patients on our inpatient service right now. So one way to try to integrate chronic kidney disease and atrial fibrillation is to understand that there is what we call renal vascular remodeling. And as we develop myocardial disease, valvular calcification, have neurohormonal activation, volume retention, measures of oxidative stress, pro-inflammatory cytokines, and changes in hemodynamics, we really have the perfect setup for the development of atrial fibrillation and this what's called electromechanical remodeling that tends to further progression of atrial fibrillation and make it permanent. We've published on the use of oral anticoagulation in end-stage renal disease, and this is a complicated diagram showing the coagulation system, showing the pathways that are influenced in chronic kidney disease, and they will come out in more of a yellow color, dotted yellow color here. But importantly, we have Apixaban, Rivaroxaban, and Edoxaban, which work as anti-factor 10A or factor 10A inhibitors. And then we have Dabigatran as our sole direct thrombin inhibitor, whereas we have warfarin that works at the level of factor 10, 9, 7, and 2. So warfarin, in many ways, is a more thorough anticoagulant than these singular agents. And in fact, one of the great tests of this is in mechanical heart valves, where warfarin has been shown to be superior and safer than the novel anticoagulants. But in atrial fibrillation, the thrombosis risk is less, and the thrombus burden is less. And for many patients without chronic kidney disease, the novel anticoagulants now are the drug of first choice for chronic anticoagulation over warfarin. Here's where these drugs work. Again, Rivaroxaban, a drug in development, Apixaban, Dabigatran, Edoxaban, and Apixaban. What you need to know is we believe that Apixaban may have a relatively ideal positioning with respect to both hepatic and renal metabolism. And if we look at Apixaban, we look at the area under the curve, for instance, the elevation in drug concentrations with Apixaban is less than with Rivaroxaban, Edoxaban, or even Dabigatran. So it may be positioned particularly at a lower dose, which there is an FDA-approved lower dose of 2.5 milligrams twice a day may be ideal. And when we look within the clinical trials, although we don't have end-stage renal disease, we can organize patients according to a renal impairment. And all the analyses so far, it looks like Apixaban has a lower annualized risk of stroke and systemic embolism, as well as major bleeding compared to warfarin. So my personal view is that Apixaban really could be ideally positioned for a drug to be used, certainly in chronic kidney disease and possibly in end-stage renal disease. So one way to put this all together now is that with atrial fibrillation, we work our way through the CHADS-VASc2 score. Greater than or equal to 2, patients go on anticoagulation therapy. We counterbalance this against bleeding risks and make a decision with respect to warfarin or a novel anticoagulant or no antithrombotic therapy. The majority of patients being on a novel anticoagulant or warfarin. And I believe nationwide now, novel oral anticoagulants for atrial fibrillation have exceeded use compared to those with warfarin. So with that, I'll transition to heart failure. So that's kind of a big dose of atrial fibrillation and anticoagulation information. And now with respect to heart failure, what we know is that there are common signs and symptoms of heart failure, which are in many ways the common signs and symptoms of patients with advanced chronic kidney disease and those on dialysis, including fatigue, effort intolerance, orthopnea, paroxysmal nocturnal dyspnea, dyspnea on rest and during exertion, and then physical exam, obviously jugular venous distension, peripheral edema, tachycardia, and then in severe cases, the development of pulmonary edema. And S3 is rarely heard, but it has a very high positive predictive value when it is heard. What we know in terms of cardiovascular disease now from the CKD population is that heart failure is far and away the most common type of cardiovascular disease in renal patients. And this wasn't the thinking several years ago where there's a big focus on ischemic heart disease, but I believe the Crick study and other analyses have really suggested that heart failure is our big ticket item in terms of cardiovascular disease and the most common cardiovascular reason why patients are hospitalized. So what you need to know about heart failure is all of heart failure can be divided into, in a sense, two phenotypes. One is reduced ejection fraction heart failure, as shown on the left-hand side of the screen. And our easiest way to classify this is a left ventricular ejection fraction less than 45%. Keep in mind a normal ejection fraction is 55 to 75%. And of those with a reduced left ventricular ejection fraction, about 2/3 have an ischemic etiology, about 1/3 have a non-ischemic etiology. In the remainder, the 50% who have preserved left ventricular ejection fraction, so-called diastolic dysfunction heart failure, what you need to know there is that the ischemic contribution is much more controversial. It could be as high as 50% or so. And so there's still a great degree of work being done on heart failure with preserved ejection fraction where we don't have established diagnostic strategies or treatments, unlike reduced ejection fraction, of which we have a dozen or more evidence-based treatments. For heart failure, keep in mind that we have both American Heart Association stages of heart failure, which is a disease stage classification, stage A being the risk for the development of heart failure, all the way to stage D, which is terminal heart failure. And then among symptomatic heart failure, we have the classification of symptoms. The New York Heart Association functional class from class 1, no symptoms, all the way to class 4 to severe symptoms at rest. With patients with end-stage renal disease, there has been a proposed classification system looking at whether or not patients' symptoms are reversed over the course of dialysis. So with volume and ultrafiltration, do patients improve with respect to symptoms? And when they get to the point of not improving, these patients have a worse prognosis, and this has now been validated. What we know among patients with end-stage renal disease, that patients with heart failure with reduced ejection fraction have a worsened survival than heart failure with a normal ejection fraction, and patients without heart failure at all certainly do much better. But this analysis suggests that patients with heart failure and reduced ejection fraction have more than a 50% mortality at 12 months. So for a nephrologist or staff managing dialysis patients, your number one problem on the problem list after their renal disease, in my view, is the presence of heart failure and whether or not they have, in fact, established cardiac dysfunction. What about our treatments for heart failure? Well, we have quite a building block of treatments for patients with heart failure and reduced ejection fraction. For those who have residual renal function, we can use diuretics to help relieve signs and symptoms of congestion. For those on dialysis, we have to rely on ultrafiltration to do that. We can now use beta blockers as well as ACE inhibitors or angiotensin receptor blockers, a new class of drugs called ARNI, which is a angiotensin receptor blocker combined with a neuropeptidase inhibitor. The brand name for this is called Entresto. This now has a class 1A indication. We can use mineralocorticoid receptor antagonists, spironolactone and eplerenone, but with great caution for hyperkalemia in patients with renal disease. We can use ivradabine, which is a drug which blocks the so-called IKF channel in the sinoatrial node and reduces heart rate. So patients in sinus rhythm with heart rates over 70, ejection fraction is less than 35%, they are candidates for ivradabine. And then we can use forms of implantable defibrillators and pacemakers to improve survival. Clearly, mechanical circulatory support at the top and heart transplant is rarely offered, but they represent the end of the line. What's off to the side now is use of digoxin, which has a very narrow therapeutic range, and as well as a combination of hydralazine and isodil and isosorbide dinitrate, as shown on the right-hand side of the screen. And the reason why they're off to the side is that it's probably a risk-benefit relationship, and as we add all these drugs, we lower blood pressure, patients become more difficult to manage, and those two drugs, both digoxin and then the combination of hydralazine and isosorbide dinitrate, probably have less to add compared to the mainstream drugs. We're very short of information in patients on dialysis. So people always want to ask, well, what do we know about beta blockers in dialysis, or ACE inhibitors, or angiotensin receptor blockers, as well as now ARNI inhibiting drugs? And the answer is we have insufficient or absent clinical trials. When we look at observational sources of data, in general, these drugs have been associated with benefit in end-stage renal disease. So those selected for ACEs or ARBs have improved survival. I've published one of those analyses, as well as those with beta blockers. With mineralocorticoid receptor antagonists, so far the data suggests that those who we select for these drugs in the presence of chronic kidney disease have a worsened survival. And it's thought that perhaps that's unchecked hyperkalemia. Much more work needs to be done, but the base of therapy, I think, for heart failure is pretty solid. And as we move into advanced treatments, we have less supportive data and have to use our clinical judgment. One of the things I wanted to point out is that in the study of end-stage renal disease and use of hemodialysis, in fact, the hemodialysis procedure itself may induce left ventricular dysfunction. And the idea here is that end-stage renal disease patients have chronic volume overload, chronic pressure overload, and the data suggests they suffer intradialytic stunning, that the process of ultrafiltration and everything that occurs in hemodialysis, in fact, causes transient wall motion abnormalities. This has all been shown in clinical studies and is related to the development of a cardiomyopathy due to the dialysis procedure itself. And once this occurs, there's increased risk of pump failure and sudden arrhythmic deaths. What we know is that the dialysis modality in the United States may make a difference. Right now, 88% of patients in the United States are in-center hemodialysis, only 10% on peritoneal dialysis, and only 2% on home hemodialysis. And more frequent dialysis, whether it's done in the center or done at home, in all the clinical trials put together, has been shown to be associated with reduction in left ventricular mass, which is a favorable thing, have fewer hypotensive episodes, and the hypotensive episodes we know are related to this intradialytic stunning process, that they on average have a better blood pressures and have a markedly decreased need for antihypertensive. So more frequent hemodialysis from the frequent hemodialysis trials program, in a sense, proved these points. And when we integrate the FHN trial, the nocturnal trial, and the Canadian trials, we show on average here that left ventricular hypertrophy is improved, considerably so in terms of reduction in left ventricular mass. All of these left ventricular mass numbers are still very high, but left ventricular hypertrophy improves. And for each 10-point increment in percentage change in left ventricular mass, there was an associated 28% lower risk for cardiovascular death in these studies. Here are the data with respect to in-center 3 times a week hemodialysis compared to slow daily hemodialysis versus peritoneal dialysis. And what you need to know here is that when we can do slow daily hemodialysis, we have a nearly 50% risk reduction for hospitalization for heart failure. And so we have improved risks for hypertensive heart disease and even ischemic heart disease hospitalization. So home hemodialysis is very friendly from a cardiac perspective. It offers a trade-off with respect to increased infection risks, but for patients with heart failure who could be appropriate for home hemodialysis, the data are strongly supportive of attempting this modality with the goal of reducing the risk of heart failure hospitalization. So in summary, daily home hemodialysis had a 20 to 25% fewer cardiovascular hospital days per patient year compared to in-center dialysis patients, a 25% lower risk for cerebral vascular disease, 41% risk reduction for heart failure, fluid overload, and cardiomyopathy hospitalization, a 16% lower risk for hypertensive heart disease. So this was an analysis that I published last year in the American Journal of Kidney Disease. One more point here, and a lot of people don't know about this, is that the vascular access may be related to heart failure risk. And what we know here is more distal access points have a lower risk for the development of heart failure. More proximal access points have a higher risk, and the higher the flow through the vascular access, while that decreases the risk of thrombosis and vascular access failure, that higher flow means a higher degree of peripheral shunting. And once we get to about 25% of cardiac output being peripherally shunted, there's progressively higher risks of cardiac failure. In fact, the chamber that fails, that's volume overloaded here, is the right ventricle. And this has now been shown in multiple studies. So we're keeping a watch on these very high flow grafts and fistulae, and working with our vascular surgeons to try to find that sweet spot with respect to good flow, but not too much for the development of heart failure. And the theory here is a ratio of the vascular access flow of 2 liters per minute. You figure, that's basically about a third of cardiac output, that there is an increased risk that with this fistula or graft, that there's decreased peripheral vascular resistance, increased cardiac output, increased blood volume return. We have higher right atrial pulmonary artery pressures, higher pulmonary left ventricular end diastolic pressures. This leads to LV dilatation, reductions in ejection fraction, and heart failure. There seems to be an activation of the neurohormonal systems when we get into this peripheral shunting. So keep this in mind: more than 2 liters a minute, more than a third of cardiac output. We're probably over the line with respect to heart failure risks in our vascular access. So to finish and conclude, atrial fibrillation is common in chronic kidney disease, and then our clinimetric tools, primarily CHADS VAS2 score, now helps us identify risk. Scores of 2 or greater really need chronic anticoagulation. While controversial, it appears that novel anticoagulants could be a reasonable choice for patients with chronic kidney disease and those on hemodialysis. And if there was a particular drug, my personal view is that it would be Apixaban at probably a lower dose of 2.5 milligrams twice a day. Heart failure is a leading form of cardiovascular disease and chronic kidney disease. The dialysis modality appears to have a dramatic effect on heart failure risk, that is home hemodialysis, much lower heart failure risk. High flow vascular access, greater than a third of cardiac output, being shunted through the vascular access puts on an additional risk for heart failure, and we may be able to modify that.
So now we will turn to the question and answer section of this webinar, and I will start with the first question, which relates to the dosing of Apixaban. So the first question relates to the dosing of Apixaban, which is recommended at 5 milligrams BID unless the patient is more than 80 years old or weighs less than 60 kilos. And so the question, the audience member wants to know if you agree with this normal dose of 5 milligram BID in end-stage renal disease, as there's a recent study showing more potential for accumulation in steady state.
Yeah, I personally disagree with that, because that age 80 and 60 kilograms was in patients with preserved renal function. And both age and weight were basically proxies for frailty and bleeding risk. And in end-stage renal disease, I think in general, patients are high in terms of frailty, and they're at proven high bleeding risks. So if we use our clinical judgment and thinking here, my personal view is that it's Apixaban 2.5 twice a day in end-stage renal disease.
Perfect. Thank you for that clarification. The second question is also similar, and the questioner wants to know your overall view on the use of NOACs in dialysis patients, and is there sufficient safety data in your view to use them?
I think right now, given the urgency for anticoagulation in end-stage renal disease, that we're going to have to go with the evidence that we have right now when we prescribe NOACs. There is a clinical trial that's ongoing, but given the fact that the sets of guidelines we have basically state that warfarin should not be used in end-stage renal disease, it becomes an ethical dilemma of whether or not we should just not treat patients at all for stroke prevention in end-stage renal disease, or if we should do something. My personal view is to err on the side of doing something, and a reasonable approach, in my view, would be a NOAC.
Okay, and preferably Apixaban, I take it.
Yes, and with the caveat that we're looking forward to confirmation from a clinical trial that's ongoing.
Okay, perfect. The next question states, could patient selection be responsible for the superior cardiovascular outcomes observed with home dialysis, as usually the best patients are selected for this therapy?
Yes, I would agree with that, that selection bias plays a large role in the strongly positive outcomes that we see with home hemodialysis. Having said that, when we do adjusted analyses for age and all the other factors, we still see a very large treatment effect. And I would also say, on the other hand, even though better patients are selected for home hemodialysis, all the studies have shown a consistently higher risk of infection with home hemodialysis. So they can't be that good of patients and that good of caregivers because we wouldn't see this counterbalance of higher infection risk. So I recognize that selection bias plays a role, but I don't think it fully explains all the benefit we're seeing with respect to this really dramatic reduction in heart failure.
Yeah, and if you would permit me, Dr. McCullough, with all respect to add to that, the trials you showed, which were the Frequent Hemodialysis Network and the Canadian trials, those were actually randomized trials. So the daily trial in particular showed a regression of LVH in the randomized trial, so there was no selection bias there. That wasn't a home trial, but it was a frequent dialysis trial, which is often done at home. What is your view for treatment in heart failure with preserved ejection fraction in CKD?
Well, my personal view about heart failure with preserved ejection fraction is I think we've missed the boat with respect to pathophysiology. I think it will turn out to be a problem of myocardial energetics, and diastole, or the relaxation phase of the heart, is much more energy dependent than systole. The heart actually more naturally contracts than it does expand to fill blood. And so simply trying all the drugs that work in heart failure with reduced ejection fraction, just trying them with preserved ejection fraction, I think was too simplistic of an approach, and all those clinical trials failed, and they failed abjectly. I think it's going to be novel agents that will come to play a role in heart failure with preserved ejection fraction. These are going to be agents that change the metabolic activity of cardiomyocytes and really allow them to energetically relax. And most of those agents are very early in development. And so I don't foresee right now any forms of therapy being beneficial in heart failure with reduced ejection fraction or with preserved ejection fraction. The best is we're going to be able to do is prevention. And there's a positive story there. Heart failure with preserved ejection fraction, it looks like weight maintenance and weight loss and exercise during life seems to be strongly preventive for the development of heart failure with preserved ejection fraction. So it's amazing. Several studies now show that exercisers and people who are fit and strong early in life have a remarkable freedom from the development of heart failure with preserved ejection fraction.
I have a question, Dr. McCullough. You presented the classification is slightly different in end-stage renal disease, heart failure versus non-end-stage renal disease because it incorporates whether the patient will respond to ultrafiltration. So does that mean that if a patient who presents to dialysis and has a large weight gain and has symptoms of heart failure, but is completely relieved after dialysis, would you still call that heart failure, or is that not called heart failure?
Well, we would call that, let's say that patient has symptoms with activities of daily living, we would call that class 3R. That means it's reversible. And what we know is that patient has a better outlook than patients who are not reversible, that their symptoms are not relieved with ultrafiltration. So it's really a prognostic classification. But I think the answer is yes, we would indicate that they have heart failure.
Okay. Okay, I think that's very important to know because in a lot of trials for adjudication of events, they often don't code a heart failure that is reversible with dialysis and requires an emergency visit as a heart failure hospitalization. But based on this presentation, you would
Well,
suggest...
no, that's true. It doesn't count as a heart failure hospitalization, but I think we would classify that patient as having heart failure. And what we know is in the observational studies now, the patients that the nephrologists classify as having heart failure compared to those that they classify as just having volume overload, that those two patient populations have actually a different prognosis. So the nephrologists seem to have good instincts in terms of who they're currently classifying as heart failure compared to those that are just classifying as having volume overload.
Oh, okay, that's good to know. And then finally, the last question that's from the audience here so far is, can we use Apixaban patients in dialysis with prosthetic cardiac valves?
No, the answer is no. We cannot use Apixaban in prosthetic cardiac valves, mechanical prosthesis. We simply can't do it. There was one randomized trial of a NOAC. It was Pradaxa versus warfarin, and it was stopped early due to valve thrombosis with Pradaxa. So we assume that if it happened with Pradaxa, it would happen with the other NOACs. So that's kind of strictly prohibited for mechanical heart valves.
Okay, and we do have one more, a couple more actually. This person wants to know about the use of ACE inhibitors in heart failure when the potassium is high. I'm not understanding the question, but I think what they're getting at is, do you have a cutoff for where you would not prescribe the ACE inhibitor in terms of potassium?
Yeah, there was one published study years ago in chronic kidney disease, and it said when the estimated GFR is below 45, I know that's not very severe CKD, but when the GFR is below 45 and the baseline potassium is over 4.5, that's when the risk for serious hyperkalemia begins. So below those two thresholds, there's almost no risk at all in the published studies. But once we get above those thresholds, a risk exists. We still use these drugs commonly above these thresholds, and we just simply monitor the potassium. I would say that when patients have baseline potassiums that are greater than 5.0, I think we are pushing the envelope with respect to hyperkalemia risk. Now, a newer approach has been to use a potassium lowering drug orally to actually pull some potassium out of the body and then still push on with the ACE inhibitor. That new drug is called Petiromir, and that can be done. Our nephrologists have done that on occasion. Because everything we can see with respect to ACEs and ARBs, it looks like it benefits patients, even deep into chronic kidney disease, as well as end-stage renal disease, provided we can manage the potassium.
Okay, that's all the questions we have from the audience. I'd like to thank the organizers of ISN and KDIGO for doing this, and thank you, Dr. McCullough, for a lovely presentation and webinar.
Okay, well, thank you. Thanks, everybody, for joining.
Thank you very much, everyone. And I would just like to add that if you have any more questions, you can ask them at education@disn.org, and we will forward them to Peter McCullough. Thank you very much.